This PowerPoint is about typical issues seen in preschool. Here's a list of some of the things that we see in preschoolers. You're going to see some repetitions from the conditions slides that we talked about in early intervention, as is not a surprise. So we're going to spend some time talking about autism. Sensory processing obviously is covered in a different voiceover PowerPoint. But mostly we're going to talk about some functional things and some of the functional issues that come up in preschool. Let's start with autism. So in the DSM-5, which has been out for a couple of years now, the definition of autism, I'm just going to read it with you here, is impaired social interactions and failure to develop social relationships. That's the first part. The second part is impaired language and communication and the occurrence of repetitive restrictive behaviors. So the repetitive and restrictive behaviors are what we sometimes call stimming. So that is the restrictive behaviors are things like most preschoolers that I know and that many other people know with autism are very hyper-focused on Thomas the Tank Engine for some reason. They have very restricted interests. Some little girls they have found are specifically interested only in princesses. And that's a little harder to tease out because is it typical for a little girl to be interested in princesses? Yes. The issue is when it becomes restricted and that's all that she will be interested in. So is it normal for little boys to be interested in trains? Yeah, sure. But if that's all they're interested in and all they want to talk about, then that's a restricted interest or behavior. So we need to look at those interests and behaviors that are very, very narrow and the child can't break out of them to do anything else. I've had children on the autism spectrum before that all they would do is line up and stack blocks. And that's really all they wanted to do. Some other children like to play with strings. So there are certain restrictive behaviors that are sort of characteristic of children, and sometimes they move from one restricted interest to the next. But when they are involved in that one restricted interest, that's really all they want to do. They also, it's the occurrence of repetitive behaviors. This is the stimming. So that's when children with autism will lay on the floor with their eye right on the floor with their head to the side, and they will make a car go back and forth repetitively. And what they're doing is looking at the wheel turning. And they seem to really like that. Or the children that like strings or string-like objects, and they hold them up in front of the peripheral vision of their eye, the side of their eye, and they just stare at it and shake it for hours and hours and hours. Some of the repetitive behaviors are the finger flicking and finger waving in front of the eyes, which some children do. And some children on the autism spectrum will be repetitive in their language. So impaired language and communication can include things like what we call scripting. Scripting is when children will verbatim repeat either a phrase someone else said or often a piece of a commercial. So sometimes when a child with autism gets upset, they'll say something like, "You'll be okay, you'll be okay, you'll be okay." And that's because that's something that they've heard somebody say to them. Other children on the spectrum, when they get stressed, they will repeat pieces of commercials or pieces of movies that they like, certain lines. And so you'll notice that these, while it is language and they use whole words and phrases and sentences, they're not connected to anything. And they don't make sense in the context of whatever verbal communication was going on. Children on the autism spectrum have a hard time with social interactions, with eye contact. They have a hard time engaging in play with other children or other adults. And they just don't understand how to create those social relationships. So they tend to play by themselves with the restricted interest, whatever they like to do. So if you walk into a classroom of preschoolers and you see a bunch of children all playing together and in different areas of the room, you'll see one child off by themselves, off to the side, doing something odd by themselves, like spinning the wheels of a car, making a car go back and forth in front of their eyes, flicking a string repeatedly, or talking to their Thomas the Tank Engine train repeatedly. And they won't be engaged with any of the other children. They'll be alone. and they seem perfectly happy. And a lot of parents report, oh, he's perfectly happy. He's a great kid, unless you bother him. He doesn't like to be bothered. So what these children don't like is if you go over and you stop them from doing what they're doing and you try to talk to them and engage them in what's going on in the rest of the classroom, then they get very upset. And, they're prone to bursts of upset outbursts. So children with autism, sometimes there are concerns with the child all along. So ever since the child was an infant, they weren't quite developing correctly. They were delayed here, delayed there. They didn't make eye contact. Maybe their muscle tone was off. Maybe their motor skills were off. And it just eventually, by the time they were 2 or 3, they got diagnosed with autism. Sometimes children that end up diagnosed with autism are developing quite fine and they look pretty good, and there's really no major concern until there is. So we don't really know if those are 2 different kinds of autism. Personally, I suspect they are. But there is not a diagnostic criteria that is different, that distinguishes between those 2 kinds of autism, if you will. There is no longer a diagnosis of Asperger's syndrome that is being given anymore in the DSM-5. People that had the diagnosis of Asperger's are allowed to keep it, but there are no new diagnoses of Asperger's for the last couple of years now since the DSM-5 has been in effect. So what they tried to do by tightening up the definition of autism was they tried to weed out things that aren't autism and try to narrow down exactly what is it. The diagnosis of autism can be conferred by a developmental pediatrician or a psychologist. And in general, the research says that the diagnosis is stable after age 2. Prior to age 2, the range of typical is pretty gigantic. And it's hard to decide if a child has repetitive and restrictive behaviors just because they do and they grow out of it. The other thing to look at is the definition of autism that you see up here on the slide. If you think about somebody with a significant cognitive impairment, significant intellectual disability, they have impaired social interactions and have trouble making social relationships. They certainly often have impaired language and communication, and they can very often have repetitive and restrictive behaviors. So we need to carefully understand whether a child has a significant intellectual impairment or whether they have autism, and that can be very hard to figure out, and some children indeed have both. So it's important for us to try to tease that out as we're working with a child. So the prevalence of autism in our world has jumped immensely in recent years. In the 1960s to 1980s, it was 0.7 to 2 in 10,000, so very, very few. And indeed, when I first started practicing as an occupational therapist, I did not have a child with autism on my caseload all the time. I would occasionally have one on my caseload and go, oh, that's interesting. And then I wouldn't have one for another year or 2. In 2005, the prevalence went from 0.7 to 2 to 35 to 60 in 10,000. That's a huge jump. And now the prevalence is somewhere around between 50 and 80, around in there, in the United States, which is just giant, right? Just the prevalence just has gone through the roof. And there are many, many people who are doing research to try to figure out what's going on. What is the cause or causes of autism? Why have we seen such incredible jumps in the diagnosis of autism? Is it because we weren't diagnosing children before and now we are? Is it because we weren't diagnosing children of color? We were only really diagnosing Caucasian children in upper middle class socioeconomic status. There's been a lot of questions, and really none of those things panned out as valid based on the enormous numbers. And there are areas in the United States that have a higher incidence, areas of lower incidence. There's areas around the world that have a higher incidence and areas with lower. And people are really trying desperately to figure it out, and it is not yet figured out. There are many, many different theories about what might cause autism. We know very clearly what does not cause autism. We know vaccines do not cause autism. The research was faked. And even though there are still some people who hold that there's a problem with vaccines, there is not a problem with vaccines. Vaccines are incredibly helpful and useful for our world and our country. When after that person put out his data, which was all faked to make his own case, it was just all fake. He put out his fake data. People got worried about immunizations and vaccinations, so they stopped vaccinating their children, particularly with the MMR vaccine. And the only reason that he thought it might be that was because it was a coincidence that the symptoms of autism often show themselves around the same time that the vaccine is given. There is no causality. There is no connection. It was just a timing thing. What happened was measles and mumps and rubella, otherwise known as German measles, saw an enormous resurgence, and it has not gone away. We have outbreaks of mumps and measles around the world, and those permanently disfigure and kill children. They're quite dangerous diseases, and that's why we have vaccinations to stop them from spreading. We've seen worldwide growth in these diseases that we had thought we had under control because people stopped vaccinating their children, because this guy sent out this fake data saying, I know what causes autism, which he doesn't, because that's not true. So we need to put the word back out there and say, vaccinate your children. This is critical. You need to vaccinate your children. The children who can't be vaccinated depend on herd immunity. They depend on the rest of the children around them not getting the disease so that they don't get sick. So our immunocompromised children, our children with cancer, our children with AIDS and HIV that can't be vaccinated depend on the rest of the community to be vaccinated so that they are not at risk. So the research, I'll get off my vaccine moment for a bit. So the research on what causes autism is still in process. We still don't know. The most recent information says that there are probably genetic predispositions, that you have some genetic leaning towards that, and then there's some environmental factors that cause that to become autism. They don't know what those genetic markers are, and they don't know what those environmental factors are, but we do know that autism tends to run in families. We do know there is a genetic component. We just don't know what it is. Children with autism are at higher risk for both gross and fine motor delays. It's important for us to understand this and know about this. When children with autism are almost always seen by speech pathologists because language and communication is a huge part of their diagnosis, as is social. So they usually also have a psychologist, social worker, special ed teacher, that sort of intervention. They also need to be followed by both OT and PT because of their risk for gross and fine motor delays. So we need to make sure we keep those at the forefront of our thinking. Siblings are at an increased risk of autism or autism-related disorders. So autism-related disorders are things like sensory processing delays, gross motor delays, fine motor delays, speech-language delays, things like that are parts of autism. Siblings are at higher risk, which again is that genetic factor, and we're not sure where that comes from, but we do know that it runs in families. Autism is comorbid with anxiety, with attention issues, and with attachment disorders. We know that our kids with autism have anxiety. We know that they have sensory processing disorders. The research is very clear on both of those. So we want to make sure that our kids on the autism spectrum are treated, or their intervention includes understanding anxiety, attention span issues. Some number between 15 and 35%, it's a large range because the research is pretty varied about it, have Fragile X syndrome, and that is the genetic cause of autism, or one of the genetic causes of autism. Other than autism as a diagnosis in the preschool years, we very often see the diagnosis of a general or global developmental delays. So there's somebody, usually the pediatrician, sometimes the parent, sometimes the teacher, notices there's the delay in acquiring developmental milestones. The child just is not hitting things when they're supposed to. Now, developmental milestones are very important. There's been some interesting research about developmental milestones, and what they found was that children who attain their developmental milestones at around the right time, around the typical time, tend to have typical gross motor skills later on, and children who don't hit their developmental milestones around the right time tend to have delayed gross motor skills. So it's important when kids have delayed motor milestones. Many times there is no more diagnosis that's specific than that. It just says developmental delay, global delay, something like that. We're not really sure what all those causes are, and they may be identified and they may not be. But in a large way, it doesn't matter to us. In a very large way, we're looking at the child in front of us. The child in front of us is trying to engage with their environment and with the people around them and the objects, and trying to play and do what a normal 3, 4, or 5-year-old does, and they're having trouble, and we're going to help them. So we largely don't care unless there are any significant contraindications. So like if there's a seizure disorder, we need to know that so we know what are the triggers to that seizure disorder if they're known. If a child has a certain genetic disorder that may predispose them to getting illnesses a lot, we want to be careful that we are very careful with our toys and our equipment and all that. The child doesn't get ill. And possibly we may be seeing a child with a progressive neuromuscular disease like spinal muscular atrophy or muscular dystrophy. We're going to want to know that because that is progressive and they're going to get worse. Or a child with arthrogryposis, which is a kind of arthritic condition that some small children can be born with, actually. So there's some things that we want to know, but for most of the globally developmentally delayed kids, it doesn't really matter. They're delayed in all areas, and we need to help them in all areas that we can. Some of the orthopedic and musculoskeletal disorders that we see in preschool are, again, similar to the ones we saw in early intervention. Arthrogryposis, CP, osteogenesis imperfecta is when the bones aren't formed correctly. If you get your medical terminology out and you look at that, it's osteo, which is bone, genesis, which is formed, and imperfecta, which is not okay. So the bones don't form correctly and they tend to break a lot. They have a lot of fractures. Spina bifida, which is causes a child to not be able to have control over function below the lesion. It's a spinal cord lesion that's at birth. It happens actually when the fetus is formed. And children essentially look like they have paraplegia. They essentially look like a spinal cord injury because it's a birth spinal cord injury. Then we have SMA, which is spinal muscular atrophy, which is a neuromuscular disorder, which is progressive, and juvenile rheumatoid arthritis. Some genetic conditions, muscular dystrophy, SMA again, Prader-Willi, Angelman's, all these, they're in your book. You can look them up, and you are all going to choose for your project, your user guide, you're going to choose one. So you can certainly choose from one of these. Some acquired conditions, which are the saddest ones of all because these are ones that could have been prevented, are traumatic brain injury, shaken baby, fetal alcohol syndrome, Erb's palsy, and traumatic amputations. Also in preschool, we often see seizure disorders. Infantile spasms is one of the very nasty ones. It doesn't sound all that nasty, but it's actually quite nasty. Infantile spasms can be lethal. It can not be. It depends on how severe it is. It's very difficult to treat, and the seizures of infantile spasms are actually damaging to the brain, so it can be pretty awful. Epilepsy is a general term for seizure disorders, and intractable seizures are ones that do not respond to medication, and those are particularly disturbing. There are some other health conditions that kids can have. Tetralogy of Fallot is a heart condition, as is patent ductus arteriosus. Patent ductus arteriosus is also called the hole between the sides of the heart. When a fetus is in utero, what's one of the things they don't do is they don't breathe, right? So their circulatory system is different in utero than it is after they're born. In utero, the blood from the two sides of the heart mixes because the pulmonary artery doesn't really do anything because it goes through the lungs and comes back through the pulmonary vein, but it didn't collect oxygen along the way because the baby's not breathing. And the baby is oxygenated via the umbilical cord, not via their lungs. So the blood in the two sides of the heart can freely mix, which it does, because there is no breathing. But once a child is born, that hole between the two sides of the heart, that ductus arteriosus, has to close because now the pulmonary artery's job has to work. It has to collect oxygen as it goes through the lungs so it can oxygenate the baby's blood. Patent means it didn't close. So a patent ductus arteriosus means the blood is continuing to mix, and that usually has to be corrected. Sometimes it closes on its own, and sometimes it has to be corrected. So what we usually know when we get a child in preschool for services is that there's something wrong. The child isn't playing with other kids. The child isn't engaged. They're not making eye contact. They're not running around the playground like the other kids, right? They're not engaging in activities like all the other children. And a lot of the time, OT is the hefty bag of therapy. We're the bag that people toss in when they don't know what to do with somebody. So I don't know, there's something wrong with them. Maybe OT can help. Because we're kind of generalists, people will often give a referral to us when they're not sure what's exactly wrong with a child. So we often get those kids. So it's up to us to really be problem solvers and analyze and figure out where's this problem coming from and who might be the correct specialist or interventionist to see the child. It might be us, but it might not. It might be that they need behavioral health. It might mean that they need to go back to their medical home. It can be all different things, but it's often up to us to tease that out. So we want to look at mental health, at behavior, at sensory, at anxiety, all that stuff carefully, tease it out, and try to figure out what's coming from where. So I'm going to give you an example of where analysis was very important to come up with what was going on with a particular child. So there's a little guy that I had in preschool, and he was in a classroom with a child who had spinal muscular atrophy and was in a wheelchair and was pretty fragile, didn't have the best head control and could easily be knocked over. And this child was very volatile, and he would throw things across the room. And scream and crash into people and all of that. And he knocked into this little boy several times and almost knocked him out of his chair, which could have been really, really dangerous because this little kid's neck was not very stable and could have really caused some serious damage. So they called me in to do behavior analysis and figure out what was going on with this child. Why was he being so volatile? So I went in and I observed what was happening and when he was upset, what he did and what upset him. I also noticed that he very sensitively would go over and help children who were sad or upset. So if there was a child in the classroom who was sad or upset, he would go bring them a stuffed animal, he would sit with them, he'd give them a hug, he would try to give them a cracker if he could. So he was very compassionate with other children who were upset. But when he got upset, he lost it, right? And his behaviors almost always happened in the morning. Afternoon, after nap, never a problem. He was a gem. He was a sweet, sweet, sweet little boy. So I watched this, and what I categorized was when he did these behaviors and what had happened before and what I thought was the cause. So what I ended up with was a pattern of misbehavior after about the first 10 minutes of class, and as soon as there were demands placed on him in the morning that he didn't like, he would start misbehaving. And usually the demand that happened right before was a verbal command to ask him to do something that he didn't like go wash his hands, like go put away his toys, right? Things that weren't his choice. And then he ate lunch just fine, and then he fell asleep immediately when it was nap time. He was not up a second, right? He fell right asleep. And he was often one of the kids that had to wake up in the afternoon. He would sleep a full 2 hours, and he would have slept more if they would have let him. And then after nap, he was cooperative. They'd ask him the same verbal direction, and he would completely comply and be sweet. So I thought that was odd, and I shared my timeline with the teachers and what I had found. And then I interviewed the parent. It was a single mom, and she was kind of lonely in the evenings. So she kept him up with her at night. And so he would go to sleep at around 11 or 11:30 at night and then get up at about 6 o'clock in the morning. That is not enough sleep for a young child. Children need more sleep than adults. So there's a very straight line between, or a correlation between age and amount of sleep needed. Younger children and babies and young children need a lot. Older people need very little, and it slowly decreases over your lifetime how much sleep you need. A preschooler needs somewhere around 15 hours of sleep a night. It varies, right? Some kids need more, some need less. But they usually need about 12 hours of sleep at night and a 2-hour nap. That's common for preschool. And this little guy was getting way, way, way less than he was supposed to because his mom kept him up with her at night. So when I found out that mom did this, I realized that the reason he was a mess in the mornings and so violent was because the poor boy was completely exhausted and should have been asleep, but he couldn't. He was overwhelmed and he couldn't get himself to sleep. And as soon as the schedule in the classroom allowed for a snack or lunch and a nap, he crashed, and then he became very well behaved after that. So that's the kind of analysis we need to do. Now, was that an occupational therapy solution? Sort of. Rest and sleep is in our framework, right? And it's in our scope of practice. But really what that was a parent education moment. And I needed to work with the parent and with the social worker and with the teacher to help the parent with other ways of filling her need for companionship and for being really clear about when her child needed to go to sleep. So we are going to do what's called a functional behavior analysis. We are going to examine the behaviors and decide what the function or what they're supposed to be for, right? What is this behavior supposed to do for the child? So this child the example that I was giving you, the misbehavior in the morning, what was the function of it? The function of it was to let us know how exhausted he was, right? So we want to carefully analyze the triggers. What happened before? These triggers are also called antecedents. What happened before the behavior happened? And it was a verbal command to do something he didn't want to do, but because he was so exhausted, he didn't have anything left to try to tell us that I'm so tired, just leave me alone, don't bother me, I need to curl up and go to sleep. We also need to look at sensory processing. What do sensory processing issues look like? They can look like a lot of different things. Difficulty with sensory processing can look like difficulty with transitions. It can look like difficulty with following directions. It can look like difficulty on the playground. It can look like difficulty with social skills. It can look all different ways. It can look like hitting other children. It can look like crashing into furniture. It can look like falling on purpose, all different things. And we need to tease it out and say, so what is the child trying to get at? Why are they doing this? Everything is behavior, as some people say, and behavior always has a reason. There's always a reason for doing something. Excuse me. What does anxiety look like? Anxiety, we talked about, I think, before, that anxiety looks a lot of different ways also. Sometimes sensory processing, anxiety, and mental health issues all look the same. They look like a kid throwing his shoes across the room, but they might not be from that reason, and we need to figure that out. We figure that out partly through doing our functional behavior analysis, partly through doing interviews with the parents, the teacher, any other people that know the child or have been around the child. We try to gather history, medical history, as much information as we can get to tease that apart. Now, one of the things I want to say about behavior and sensory is that while they may look the same, you have to intervene very differently. And the other issue is that children that have sensory processing disorders often end up with behavior problems, because a child with a sensory processing disorder is the child that doesn't like to be touched and is very, very uncomfortable all the time in their skin. So the parents might go out of their way to always let them wear pajamas to school. So now there's a behavior that the child won't wear clothes, and it gets to be a problem in the winter, or it gets to be a problem on school picture day when the kid's wearing their pajamas to school. Or when the child gets older, it gets to be a problem because now they're being teased by other children. So we have to understand that some of the sensory processing disorders of younger children end up as behavior problems very quickly. When we have a sensory processing disorder, we are going to approach it from the sensory end. If someone is tactily defensive, we're going to try to help them reduce their over-responsivity to tactile stimulation. If a child has an auditory sensory processing problem, we're going to reduce the auditory environment, maybe talk about headphones. If they have issues with visual information, we might have them wear sunglasses in class, or maybe a hat with a brim, and we might talk about reducing the visual input in their environment, in their house and in their bedroom. If these things are behaviorally based, then we have to go about it from a reinforcement end of things, which we'll talk about in a little bit. So we're going to approach it differently depending on what it's from. So behavior strategies. We want to have clear boundaries. Children love boundaries. They push at boundaries regularly, and they push at them because they want to know they're still there. If every time a child pushes at the boundary moves, they're going to push harder and harder and harder because they desperately want to know where it is. So let me give you an example. Little child goes over and wants to touch a plug, outlet, right, plug thing, and goes over to touch it, and mom says, no, plugs aren't safe, and picks up and turns the child and redirects them somewhere else. And the child goes, plugs aren't safe. Let me see if that's still true. And the child crawls over again and looks mom right in the eye and reaches for the plug, and mom goes, nope, I told you, plugs are not safe. We can't touch plugs. Picks the child up and moves them. Child's going to try it a few more times and look at mom for the reaction because they want to see, is this for real? Is this a real rule? And when they finally get it, they're not going to do it anymore. They're going to avoid those plugs because they know that rule is for real. Then let's switch the scenario without clear boundaries. The child goes over and tries to touch the plug, and the mom goes, nope, no plug, and picks up and moves the child. The next time the child goes over, looks at mom, tries to touch the plug just like before, but mom laughs and walks away. The child goes, oh, I guess I can touch plugs maybe. Then the child tries to pull the plug out of the wall, and somebody goes, ups, and hits the child's hand and walks away. Now the child's confused. Is it okay? Is it not okay? Do I get hit? Do I hit the plug? What do I do? And then the child tries it again, and nobody's paying any attention. So they keep yanking at it and hitting it and making a lot of noise to say, hey, everybody, is this still bad or not? I don't know. So they yell and they scream and they hit the plug and they jerk on it. And then the parent gets really mad and sticks them in their crib. Now, what has the child learned? Absolutely nothing, right? So that child is upset because he doesn't understand the boundaries. When we keep our boundaries consistent and clear, and our response is consistent and clear and without emotion, just clear, then the children learn. So one of the things that people do is they threaten and then they never follow through, right? That confuses the heck out of children and gets them very, very upset. It doesn't work at all. So if little boy, so Bobby is hitting Susie, his little baby sister. So Bobby goes over and hits Susie, and mommy says, no, don't hit your sister. Stop it. And he goes, I guess that was a no. And then he looks at mom and he tries it again. And mom says, why are you looking at me? And doesn't say anything about the hitting. And he goes, oh, okay. And then the next time mom says, if you hit her again, I'm going to put you in your room. And he goes, oh, okay, well, let me try it, right? The kid's got to try it because you just said, if you hit Susie again, I'm going to put you in your room. So Bobby goes up and hits Susie, and the mom says, I told you if you hit her again, I'm going to put you in your room. And Bobby goes, well, that didn't happen last time, so let's see if it happens this time. And then Bobby goes to hit Susie again, and the mother just loses it and hits him, right? Because he's not listening. Well, he's not listening because the goalposts keep moving, and he doesn't know what to do, and he needs to test the rule to see if it's true. So you have to be consistent and clear with everything. You want consequences to be as logical as possible. So you don't want consequences like, if you hit Susie again, I'm going to put you in your crib. That doesn't mean anything, right? So don't threaten unless you're willing to follow through, and make sure that the consequences are logical. So if a child is supposed to put their coat on before they go outside and they refuse, well, I've never been bothered by that, because I'll always say, okay, and I'll just take the coat with me and say, let's go then. It's cold out there. And then the child will get cold. And that's the consequence. They're cold. And I'll have their coat anyway. And then the child will say, I'm really cold, Mommy. And then you say, well, would you like to put your coat on now? And they go, yes. And you're like, okay, I brought it. Here it is. Put your coat on. And you don't require the child to lose face. You don't say, I told you it was cold out before. I told you to put your coat on. Now you have to do it. That just embarrasses the child. And that's not reasonable. We don't need to do that. We just give it to them and say, okay, here's your coat. Put it on. It was a consequence. They understood. They went outside without their coat. They got cold. Their coat was provided. They feel better. They learned the lesson. They probably won't do it again. And withholding the coat is just going to get the kids sick. That's not what you want, right? So you have to think about it logically. So, for example, if you want your child to clean up the room, first you have to think about, why do I want my child to clean up their room, right? Is that important for some reason? What's the consequence of not cleaning up your room? Well, you step on things maybe, or you can't find things, whatever it is. The consequences should be as logical as possible. And the other thing to remember when you're talking about behavior and children is to try to control your affect, or the way your face shows emotion. Screaming, yelling, all of that stuff does nothing. It just escalates the situation and makes all the behaviors worse. So the way to get the best compliance out of a child is to have an even tone and just tell them very clearly what the consequences are of their behavior. And then follow through. Make sure that the consequences, that you will follow through on them. You never say something like, don't do that or I'll kill you, because you don't mean that. So make sure that when you say something that you mean it. For sensory strategies, we're going to find the triggers. We're going to find out, is it auditory? Is it visual? Is it tactile? Is it movement and vestibular? What is it that's causing these behaviors? And what anxiety is triggering these behaviors? So what's going on? Pay attention to the sensory load. What else is going on in their environment? And try to put them in a low sensory stimulation environment and slowly introduce stimulation to get to be a normal level. So we don't want the child to have to live in a bubble. I like their bedrooms to be as comforting and low anxiety and low sensory stress as possible, because that makes sleep much easier and more beneficial, and children who are sleeping well are going to be much better behaved and have a much easier time in life. So you want to keep their bedroom as sensory neutral as possible. No TVs, no choo-choo trains running around the ceiling, no bright loud carpets, no bright loud bed covers. You want to keep it as simple as possible so that they go into a comforting, minimally stimulating space when they go to sleep. We like to teach children how to manage their own sensory overload. So we'd like to give them language and information to say, oh, you don't like it when it's loud, do you? How about you put these headphones on? Maybe that'll help. And that way you're giving the child some language and a way to compensate. So you're saying, I know loud noises bother you. We both know that these headphones help. I'm going to give you some control over when these headphones go on and when they don't. I like the children to be in charge of wearing their sunglasses or putting on their headphones or whatever sensory de-stim thing that we have come up with. So the sort of top of the hit parade of why children are referred to occupational therapy in preschool, the biggest one I've found over the years is difficulty transitioning during the school day, trouble getting on the bus, getting off the bus, going from the playground to the classroom and vice versa, and all that sort of stuff. That's usually the main reason people refer a child to me for OT. They also refer children for OT when a child is disruptive, doesn't follow directions, doesn't behave, all that sort of stuff. I've had quite a few kids referred to me for biting, hitting, pica, all that sort of thing. Pica is the purposeful eating of non-food items. And then the other referral reason is children that can't manage classroom tools, like they can't hold a crayon or a marker, they can't use scissors, any other one of those school class tools. And who do we refer to? We need to refer out when something is outside of our scope of practice. So if a child has some serious behavioral health issues, mental health issues, we need to refer them to a mental health specialist. If we suspect a child has medical issues, we need to send them back to their medical home, whoever that is. If we suspect that there is something educational going on, maybe some intellectual disability, we need to refer them back to education. So we need to consider when it is inside and when it is outside of our scope of practice and refer appropriately.